I'm going to discuss, and the last discussion is on table. On table, a surgeon is doing a laparoscopic cholecystectomy. On table, the surgeon is doing a laparoscopic cholecystectomy. He found out there is a duct injured and bile is coming out. There is a duct injured and bile is coming out like this. So we don't know what is the injury, because in laparoscopy, the bile starts coming out. We will not know the clear anatomy. If there is a bile starting to come out during the surgery on table, if the hepatobiliary surgeon is available, for example, they are calling me on table, I'm going on table to the theater. On table to the theater, what I will do is, for MCQ, please remember, if the size is less than 3 millimeter duct, some duct it is leaking. I found out where it is leaking. For there is some duct which is less than 3 millimeter. I can tie the duct, nothing to worry. Tie the duct. It will be some abnormal duct or a minor duct. Tie the duct and come out. Clip the duct and come out. If it is more than 3 millimeter duct, what should I do? Very interesting point. This is the point which as a postgraduate aspirant should know. If there is an injury of a duct more than 3 millimeter, means it can be a CBD also. There is an injury like this in the CBD like this. The surgeon, while doing laparoscopy, he has cut the CBD like this. If the circumference is less than 50%, circumference is injured. More than 3 millimeter duct, I'm going to open up and I'm doing the surgery. I'm going to just what I'm going to do. I'm going to open the abdomen. More than 50% circumference is injured. At every point of this time, I'll tell you, you should never hesitate. If there is a bile leak, some bile is coming out during laparoscopic cholecystectomy, never hesitate to convert it to open. You should never hesitate to convert it to open. Immediately convert to open. And if the duct size is less than 3 millimeter, tie the duct. If it is more than 3 millimeter, and if the injury is less than 50% circumference, I can do the repair on a T-tube. I will keep a T-tube. I will repair this. Keeping a T-tube. Simple concept. This is as an MCQ, not only for MCQ, this is what given in Bloom Guard also. So less than 3 millimeter duct, tie the duct. More than 3 millimeter duct, open the bile duct and keep a T-tube for less than 50% circumference. This all can be done on table. Please understand the point. On table, not post-operative. If this happens after 24 hours, I will never open. If the surgeon has injured the bile duct and the drain is coming with the bile, patient comes to me after 24 hours. Within 24 hours, I can even redo. If the patient is operated and 6 hours to 12 hours, the patient is coming to me, I can even open and redo. But if the patient comes after 24 hours, all these things cannot be done. On table or yearly referral. Yearly referral to hepatobiliary unit, hepatobiliary pancreatic unit. If it is being done, yearly referral, there is no strict protocol, but it should be before 24 hours. This is what I will tell. So before 24 hours, if the patient reaches the hepatobiliary surgeon, we will open. And if it is a 3 millimeter duct, tie the duct. More than 3 millimeter duct, we have to put a T-tube for less than 50% circumference, and more than 50% circumference, I should do a what? If it is more than 50% circumference like this, the injury is more than 50%, I should bring a rule limb of jejunum and anastomose like this. Hepatico-jejunostomy should be done using 4-0 Vicryl. Using 4-0 Vicryl, hepatico-jejunostomy has to be done, because if I try to repair more than 50% circumference, it will definitely develop a stricture. If less than 50% circumference, I can keep a T-tube now and I will remove the T-tube. That is different protocol. That and all, I'm not going into CBD stones or CBD management, and I'm not going. But if less than 50% circumference, please put a T-tube and come out. So this is very important thing you should not forget for your exam. So this is about the various concepts of laparoscopic cholecystectomy. So related to CBD stones, I'm not discussing in this chapter because this module is not related to CBD. So in future we'll have some other session for a CBD stone discussion. Now let us come for any doubts you have, we can discuss. I think we have completed the session. Any doubts you have, you can always post in the chat box. So thank you for all attending the session sincerely.
Yes, sir. So thanks a lot for the wonderful session, sir. I'm pretty sure that our junior doctors and medical students learned a lot from you. And the session is of great value, especially for those who are appearing for the upcoming NEET exams next month.
Yes.
Thanks a lot, sir, despite your busy schedule. So we are coming to the end of the session. If audience have any doubts, please
I think they're putting so many questions. Actually, you have to thank you. I am one of the first laparoscopic surgeon. Dr. Mohan sir is on the show. He's from Viluppuram. Dr. Mohan sir is active IMA member. Maybe Abdul Azam sir maybe knowing. He's a senior most surgeon, and he is the first surgeon in Viluppuram district to do laparoscopic cholecystectomy. He wanted to attend the session and he's attending. Thank you, Mohan sir. Thank you so much for your thing.
Great. So can I read
Any
the question?
You can post any questions. Any doubts you have, friends? Please post the doubts if you have. We are watching the chat box. Any doubts related to the session, you can please tell. So Himanshu has asked about Ganesha sign. So Ganesha sign is not an important as an MCQ. As an MCQ, it is not important, but I hope you understood after that image. I showed, you know, that like a elephant's head and that thing. Elephant's head corresponds to the gallbladder and the trunk corresponds to the cystic duct. So that is known as Ganesha sign. We'll be having a Ganesha sign while doing the surgery. Thank you. Any other doubts, please post. So Shaurabh Chaugan is asking about Ganesha sign. Let me share the screen and I will explain about it. So Ganesha sign is not for MCQ. It's a funny sign, not for MCQ. For those who want, those surgeons who are practicing, you can understand what is this. So please remember, this is a gallbladder. So while we are doing the dissection of the cystic duct, what happens? This area looks like this. This looks like a elephant. You can see this looks like a cystic. This is a cystic duct, and this is the Hartmann's pouch and the distal part of the fundus. So it looks like, when I'm seeing from here, it looks like a Ganesha sign. That is known as Ganesha sign. You can understand from the video I showed, you know, I'll show you the video now. You see this video, you'll understand the Ganesha sign in this video. In this video, you can see the Ganesha sign. Can you see? This is the Ganesha sign. Can you see the Ganesha sign? You can see the, sorry. This is a typical Ganesha sign you are seeing here that moves. When I try to write down, it is moving. So please see this picture. This is a typical Ganesha sign. You can see what this is holding is the head of the elephant. This is a trunk of the elephant. So this is this thing. Now I don't know how to tell in English. This is one which is looking like a Lord Ganesha. This is Lord Ganesha sign. Okay, please don't forget this.
Yes. Sir, we have a question from Dr. Abhishek. He's asking what to do if mass is found on gallbladder after cholecystectomy.
So after cholecystectomy, if there is a mass, we have, that's a separate protocol. I didn't discuss. I'll tell you. If there is a growth, found in the biopsy specimen, so you have operated thinking it is a normal gallstone, but biopsy report, the pathologist is calling you, sir, biopsy report has come as cancer. Now immediately you should ask the biopsy report whether it is T1A, T1B or T2. It cannot be T3, T4. Why? The biopsy report can be only T1A, T1B or T2. I'm telling you it cannot be T3, T4. T3 is tumor involving serosa. Definitely the moment you put the port, you would have found out it is a cancer. T4 is involving adjacent structure like liver infiltration. That also you would have found out when you put a port. So when you are doing a laparoscopic cholecystectomy, when you put the port, you see T3 cancer, T4 cancer. Already I told you what you should do. You have to refer to a GI surgeon if you are a general surgeon. You have to do open surgery when you are a hepatobiliary surgeon. So T1A, the tumor is involving only up to the muscularis mucosa. You have to know where it is involved. So T1A, the tumor is involving mucosa. The tumor is involving mucosa is T1A. So muscularis layer is T1B. Why T1B is muscularis? I hope you know very well. There is no submucosa in the gallbladder. T1A is mucosa. T1B is muscle layer. Okay, T1B is muscle layer. T2 is going up to the serosa. It is not infiltrated, but it is going up to the serosa. So T1A mucosa, T1B muscularis layer. We can just laparoscopic cholecystectomy is enough. So laparoscopic cholecystectomy enough for T1A and T1B, and we go for margin positive. We have to go for redo surgery. When the margin is positive, I have to go for redo surgery. Otherwise, laparoscopic cholecystectomy is enough. T1, which is infiltrating up to the serosa, it has gone up to serosa as per the biopsy report or extended beyond. We have to reopen and do the surgery. Reopen and do extended or radical cholecystectomy has to be done. So this is a separate topic. It's a big topic to be discussed. It is a topic on CA gallbladder. So biopsy report comes as T1A involvement of only mucosa. This is the usual question for PG aspirants. It is involving only mucosa, means already done laparoscopic cholecystectomy enough. Already done surgery is enough. So remember, this is the only question they will ask you. If it is involving only up to mucosa, already done laparoscopy is enough. If it is involving up to the muscularis layer, we have to look for the margins. If margins are positive, we have to go for re-laparotomy and proceed. This is for the